Hello, everyone. Thank you for attending the Autoimmune Registry June webinar series, where we bring together the best and the brightest in the autoimmune community and allowing the sharing of information between all the vital patient organizations that help our patients care. I have the luxury of introducing Maria Morais. She's the Vice President of Advocacy for the Canadian PBC Society, which is primary bile cholangitis. And I am tongue-tied because that's how I am today. With that, Maria, so I'll turn it over to you.
Reggie. Thank you. A pleasure to be here with all of you today and those that will be reviewing the recording after. I am a patient. I'm a patient advocate. I'm a registered nurse. I'm a recipient of a liver transplant. And I would love to share my story with you today, and most importantly, tell you about the Canadian PBC Society, the primary biliary cholangitis, rare autoimmune liver disease, and share with you some learnings on how we cultivate support, credibility, and influence to do our work. We are a totally volunteer-run organization, and happy to be with all of you today. So for today, I wanted to share with you about the Canadian PBC Society. I wanted to talk about what is PBC, the disease, the symptoms, and some management of our unmet needs as patients, and talk about some of the going forward research and new treatments that we are trying to advocate for our membership. And recognizing that this series is often heard and participated by other patient groups that are trying to do advocacy, to share some of the strategies that we've been employing, and learning from others as well as we partner and engage with other organizations such as yourselves to share common strategies and interventions that we all can use in the space of advocating for our members. And then lastly, just share some insights that we have, and an opportunity then to go into Q&A around sharing our experiences with what's been successful, where we haven't been as successful, and just inspiring all of us to be able to continue to do this hard work. With that, I wanted to just to start off with who are we? So the Canadian PBC Society is a Canadian national registered charity, first founded in 2003. And from what I understand, that it was a very, very small group of women, middle-aged women, that found themselves with a diagnosis of PBC, but did not have any connections with other people, other patients, and so felt very isolated. So it was a very grassroots formed organization back in 2003. And to this day, it is continuing to be a volunteer-based board. I am on the executive as an executive member. This is my second term this year. I became a member in 2019, just as someone who was newly diagnosed, needed to find my space in this liver disease, rare liver disease, and found the society. Attended an initial conference just to empower myself with knowledge. As a nurse, I had never heard of PBC. So, I wondered how rare it was, and have found my space with others As a result of going through the disease very, very rapidly, and unlike many of the other members who have a slow chronic progression, I then became a very active member on the side as a volunteer. My regular job is working within a public health unit in Southern Ontario. That's my full-time position as a people leader. But I wanted to give back. I went through the disease very quickly, very rapidly, with all the symptoms, all the stages of the disease, and then unfortunately went into needing to have a liver transplant in 2021. So here I am today. The organization is dedicated to improving the lives of those that live with primary biliary cholangitis. And from now on, I'll probably talk about it as PBC, which is a much shorter version, and with the mission to really raise awareness about this rare liver disease. Gain support for research. We don't know too much about it. It's a disease that's still evolving, but happy to say that a lot of effort in the research world is being emphasized on PBC. So I've throughout this presentation, I'll talk about those efforts. And we really want to have a place for our members to have access to managing the illness, the chronic illness, and treatment options, so medications, and very much operating in partnership with several pharmaceutical companies that have an interest in researching, producing key molecules that can start to really meet the needs of our patients in treating, managing. There is no cure, but managing this disease. We are also set up across Canada, our different provinces across Canada. We have regional volunteer members that then support their local members and provide support, education, some fundraising activities, and all towards sort of researching and understanding and supporting our PBC patients. The organization is also supported by a very well-established network of medical experts and leaders, key opinion leaders within the PBC research world and globally, internationally, globally, locally, and really proud of that. One of the things that has been established is a patient charter that really says to everyone, and especially to our members, of what we believe in from the organization, and to support families and care providers and caregivers, care partners, whatever term you're using these days, that all of those players have rights in the disease of PBC. And those, we've set out 10 of them. And really they talk about how patients can feel empowered to have an early diagnosis. Well, that's what we're trying to do as an organization, is to bring awareness so that our members, even before they become members, people in general with the healthcare system, have an accurate, timely diagnosis that then can access care, so that the earlier the PBC disease is caught, the higher the chances that people will live well with PBC. We also want to increase educational resources for our medical community. And because it is a rare liver disease, it's really not something that's common in the medical curriculum. So we want to bring more awareness to general practitioners, specialists. There's hepatologists would be the ideal medical community that does diagnose, but that's not the first point of contact for most of our patients. Because it is an autoimmune disease, patients may present in rheumatology, in gynecology, in ears, nose, and throat. We'll talk about some of the comorbidities and other autoimmune diseases that may be associated or that people may also live with, that is also represented in this autoimmune registry that most of you would be familiar with. So just providing that general information. And then obviously once diagnosed that people are hooked up with specialist care, and that our members have access to medical treatment that is quality treatment, approved treatment. So there's a lot of regulatory efforts that also our society supports and lobbies for. That peer support programs are really important, where people can talk to others about their experiences. Of course, equality, equal access to care in Canada to be able to be treated. We also want to share and improve public awareness of PBC, and psychological support. So this is a long-term disease, autoimmune disease that can wreak havoc with mental health and psychological needs, and having the opportunity for that psychological support. And of course, protection against any sort of discrimination from care. So what is PBC? As I've described, it is a chronic, rare, autoimmune, progressive liver disease that affects the bile ducts of the liver. And mostly it's the small bile ducts of the liver. There are other autoimmune liver diseases. So one of our sister diseases is PSC, primary sclerosing cholangitis, and that affects the larger bile ducts. And acts very similarly, but the treatments are different, similar but different. If caught in PBC early diagnosis, we can slow the disease progression a bit. Of course, genetics and environmental factors may be the cause, but that is still something that is quite not known. A lot of efforts are being looked into our environmental factors. So maybe genetics plays a part, and then once someone is in conditions and factors in the environment that triggers something, to cause the PBC to be triggered and disease process. We know in general with autoimmune diseases that there is something about the environment. We're seeing a lot more in general autoimmune diseases in our population that was never really something that was identified or talked about, but perhaps we just know a little bit more. And as I said, there is no cure. So who's affected? Usually it is women, more so than men, in sort of the middle age group of 35 to 60 years old. I myself was diagnosed in my early 50s, around that mark, so I fit the bill. But it also is interesting because perhaps in other autoimmune diseases, that is a general age group as well. I did have other earlier diagnoses of autoimmune diseases, such as Raynaud's phenomena. And since being diagnosed with PBC, I have other issues that have been diagnosed, such as Sjogren's disease, lichen planus, which is lesions in my oral cavity, my mouth. I have mixed connective tissue disease, which is a very, very generalized tissue disease throughout the body. I've also been diagnosed with scleroderma of so the tissues within my lungs. So since the PBC, it's like I've received, we often talk about that autoimmune diseases like to hang out with one another. So that I'm obviously observing in my own body. If it is diagnosed in younger women, it can be a little bit more severe with a progression towards liver transplant. Um, and men, if they are also um, diagnosed with the disease, they too often go to transplant. So there's something about men with the disease that either they're not diagnosed early enough, and when they do get diagnosed, they're already in late stage liver disease, which would mean cirrhosis of the liver. Um, and um, and so that is sort of the description of who's affected. In terms of the symptoms, so initially there's some generalized fatigue that not everyone has, but if you have it, it can wreak havoc with your quality of life. And fatigue, not being tired, but more of a you just can't move, or your body is so heavy. Um, Often there is itch, pruritus, as it's named, that may feel like bugs crawling on the hands, feet, torso. Often, late at night perhaps is worse. After I found that after eating my dinner, I would have more of an effect of itching, that it was uncontrollable, left red marks, excoriation of the skin. I also did start with abdominal discomfort, so gastro issues, lots of diarrhea, which then I was led to being diagnosed through a gastroenterologist who had studied under a guru around PBC and knew to kind of look for that, suspected. And then I was sent to a hepatologist to confirm. Brain fog can also be something that is an early symptom where you just feel kind of foggy and cognitively not super alert in terms of making decisions or forgetting. I certainly felt that very deeply. It turned into a later symptom for me on the other side, hepatic encephalopathy, which is really a toxicity of the brain because of the bile buildup. Often we see sleep disturbances as an early part as well, and whether that's associated with, fatigue and never feeling real well rested, so that during the night you just can't settle because you've maybe rested during the day, um, and perhaps, busy itching and scratching. Later symptoms can then turn into dry eyes and mouth, which often is associated with other diseases, but it's certainly a primary. Some pain of the abdomen, ascites, which is buildup of fluid in the body. For me, it was in the abdomen where I ended up having to have 52 paracentesis, which is drainage of the abdomen, a procedure that I went in weekly to drain, unfortunately, 10 liters of fluid every week. So I would be putting on about 20 pounds a week. So my body was fluctuating in weight incredibly throughout the week. Not fun at all. But again, it is late stage disease, and not many of our members are experiencing that. Yellowing of the eyes and skin in later disease, called jaundice. Also, osteoporosis can be associated with the disease, and so some bone and muscle wasting, joint pain, some bleeding of the gastrointestinal area, as well as bleeding of esophageal and rectal varices. And I had to have, over a 5-month period, some banding of some esophageal varices as well as rectal, that really affected, my ability to eat and recover well, and loss of weight. I lost about 50 pounds at that point. Some portal hypertension because of the buildup and the ineffectiveness of the liver processing all it needs to do. There is some hypertension that happens at the portal vein of the liver. And because the liver has a lot of properties around bleeding and red blood cell, and not producing proper red blood cells, there is some bruising and bleeding that then causes on the skin, and you can certainly see that. Moving on then to other diseases that might be associated. Sjogren syndrome with dry eyes and mouth is seen. The Raynaud's phenomena, which is something that I experienced, as well as the constriction of small blood vessels in the hands, feet, and throughout the surface of the body. So if anyone has it or has experienced frostbite, where the hands go very white because the capillaries in the hands, the blood vessels constrict because of the cold or a response to cold. They go white, and then when they start to warm up, they can turn very, very purple and painful. And if you're not careful, you can have lesions on the digits and fingers. Other things like thyroid disease, rheumatoid arthritis, osteoporosis, scleroderma, systemic sclerosis, so hardening of the connective tissues throughout the body, and other bowel concerns, that are chronic, celiac disease being one, and other digestive disorders. So it is really not a fun disease, and autoimmune diseases in general, but we are seeing a collection of these other diseases with PBC. How we diagnose is really through very simple, if healthcare practitioners are knowledgeable about how to go about and do that, through a blood test. So checking out the liver function tests, and in particular the alphosphatase feature of our liver enzymes are high. And if they're consistently high, then that's something, a trigger for the healthcare provider to further investigate. From an antibody stance, checking the AMA, the anti-mitochondrial antibody, that would be present as positive. And we also have higher levels of cholesterol, not because of the food we eat or anything, it's just the processing through the liver, and it demonstrates as higher levels. The diagnostic imaging that used really is an ultrasound of the liver to check for scarring and fibrosis and late stage cirrhosis, and hopefully that is not the case, but it's ultrasound stages from 1 to 4, stage 1 to stage 4, from scarring, fibrosis to cirrhosis, and can also check the bile ducts, and often there's inflammation of the bile ducts with PBC. Further to that, a fibroscan of the liver to detect the level of scarring, and that's where you get staged, and it's a value that is received from the fibroscan imaging of a kilopascal. So it's a measurement of scarring. Also some MRI type imaging of the bile ducts. Less frequently done these days is a liver biopsy. I did not need one because the blood tests and the imaging tests were for sure diagnostic. But if things are still, unknown, then obviously liver biopsy is an option. Moving on to management and treatment. So, the disease can be managed. I don't want to give the perception that it cannot, because it was my experience that I was diagnosed maybe pretty late or whatever in my genetics, although no one in my family is positive for PBC, but we do have other autoimmune diseases. But I want to really just emphasize that for our listeners that PBC can be managed. But I'm, certainly giving you the range of the disease in this presentation. So managing through healthy lifestyle, healthy eating can be and is certainly a mandatory and supportive piece because vitamins and minerals sort of get depleted with this disease. The liver does process a lot of what we intake, and supplementation with vitamin A for immunity, for vision, etc. Vitamin D for our bones because osteoporosis can be something, and fragility, we're at risk. Vitamin E for our skin and connective tissue development, and K for, blood factors and keeping ourselves healthy, and as well some calcium for our bones and prevention of osteoporosis. Lifestyle changes, really a healthy diet, nothing too specific, but knowing that we don't absorb these vitamins and minerals effectively, to really pay attention to our diet and increasing key vitamins and minerals. And protein is really important if you're losing body mass. I should say in here, being active as well as part of that healthy lifestyle change, and walking is a very basic and important piece to keep moving. With medications that we have, itch, really, there are not a lot of compounds on the market that can help the itch. There are things that people can do, but it's really a trial and error, and that's why research continues in that area. Most basic is ursodiol. UDCA is a medication that all our members are on. And then there are some other second line therapies that are approved in some countries, not approved in others. If you're reading or hearing us from the States, you have a few more options that have come in this year, and Canada into later this year and next year. And lastly, certainly not a treatment option, but something that may be necessary is a liver transplant from a deceased donor or a living donor. In my case, I had a friend of mine donate 60% of her liver to me, and I'm ever so grateful. I wanted to provide you some information about our patient population. We did a survey around understanding where our patients are at in terms of the disease, and this was last fall, 2024, where we received 377 patients completed the surveys. I think we had probably about 450 that started but didn't complete, so for whatever reason. And we identified that 97%, apologize, 97% were in fact women, so that holds true as a disease of women. Most were of white European descent, and the largest group were from 61 to 75 years old, and 87% were from Canada. We had an interesting understanding that 47% of those that answered, and obviously from 61 to 75, were retired, and 27% were working full time still, and 13 on either sick leave or disability status. So under the work piece, people are volunteering, so that might be categorized as working or being a student. One of the important things that did come to light within the age group of 31 to 60 is that they're on disability. So we look at the 30, the bottom end of that, and the fact that people are struggling with work and PBC, and I can totally relate to this, having had the disease at its height and trying to work, trying to be a mother, trying to be a professional, trying to be a wife, a friend, a support person. And one of our members indicated here as a quote, "I had to take a disability leave from my job. I loved as a job that I loved, experiencing pain, fatigue, brain fog was just too much to keep working. And after a long battle with disability plans, had to go on a CPP, which is um, disability in Canada." Diagnosis and medications in this survey, we found that most people got diagnosed at 51, which is certainly within that category, but may in fact be a little later than ideal. And most being diagnosed between 2016 and 2022, and on the medications that we would expect. And most felt that they were being well managed, which is really great. In terms of the symptoms that sometimes or often were identified, the number one is fatigue. And, one of the things that we are concerned about when our members do go to their healthcare provider to say, "I'm just feeling not well. I'm really fatigued," often get dismissed and not heard, because fatigue in, a middle-aged woman could mean a whole bunch of things. It could mean you're taking care of the, intergenerational piece. You're maybe suffering with menopausal symptoms or disease processes. So a whole number of things, and one of the things that we try and empower our members is to talk to your physician and really, say, "No, this is not normal being tired. This is a fatigue, a brain fog." And that was the second piece that highly got identified as a symptom. And itch being the third top. We also saw in the survey, as predicted, comorbidities, being people living with more than one of these chronic conditions. And so we identified 62 unique conditions, things like psoriasis, Zika, chronic kidney disease, CREST syndrome, which I experience as well. So that's a collection of 5 diseases that make up the CREST syndrome in an autoimmune situation. And more than 6 autoimmune diseases, 5 people reported that, which was pretty fascinating. Certainly, we see a lot of implications for PBC and daily living. 80% of our patients experience some impact on daily living. So being able to provide, stability in families and being the caregiver of within the family. So something really important for us to keep in mind. when we asked what improvements they would like to see in new treatments, and patients often talked about improvements in treatment for the fatigue and itch, which is still very much a gap. We like to collect patient voices as storytelling about the disease, because it's really difficult to treat some of the symptoms. And often we, in the healthcare field, treat the clinical aspect, trying to lower the liver enzymes rather than the quality of life and the symptoms. So, documenting things that people say about their itch, their fatigue, their brain fog, and the social isolation that it can cause, and certainly the anxiety. So where do we go from here from the patient survey? We identified 3 priorities. Keep listening to patient voices and experiences. Strengthening access to specialists and multidisciplinary team and care, knowing that the autoimmune diseases are more than just a hepatologist's responsibility. There might be rheumatology, there might be, bone specialists, etc. And thirdly, to promote research into symptom relief and quality of life. And that continues a big, big gap in what we are trying to advocate for. This, I apologize, it is a picture of a recent conference I attended, and it really is targeting, from short, intermediate, and long-term targets for the disease around how the medical profession is really trying to tackle this disease in reducing the fibrosis and decreasing the need for transplant, which is the goal right now. And so Dr. Hirschfield, one of our key knowledge physicians, talks about 5 areas that we want to drive from, quick, swift, clear diagnosis to really championing innovation and excellence in PBC, where we individualize treatment and care for people, recognizing that everybody is unique and individual, in order to manage and monitor their symptoms and keeping equity in mind. So moving on to the 3 strategies of this session, demonstrating support, building credibility, and cultivating influence, I wanted to highlight the things that we do in our organization. So we do support across Canada, with each province having regional and local volunteers that then support further on the ground. We have a national executive board. We have a volunteer training support program if you want to be a volunteer to peer support. There is a training that we have people on. We have a membership database. We have probably around 2,000 members. So once diagnosed and they find our society, and we're trying to advocate with other healthcare providers that we do exist and the kind of support we have. And I personally manage the database, which is really a registry of all our patients, of their names and where they live, but we don't collect their specific biomarkers. Where we send out new member packages and make connections with their local coordinators. We often put on a biannual conference where we have our medical experts speak directly to our PBC patients and their care providers. We suggest that they bring someone along. We provide awareness campaigns, Facebook pages, education materials, patient dinners, where we support either the local doctor, hepatologists come out, and an opportunity for people to gain support, and other informal connections, coffee clutches, email support, telephone calls, that kind of thing. This was our recent conference in June, early June, Thrive in 25 for our PBC members. We also had a series of Thrive in 25 Zoom calls over a 3-month period earlier this year to talk about connecting to your local coordinator. We had a healthy eating session, those kinds of things. That's myself on the left hand there with the president of the PBC Society doing some fundraising. And on the right is some campaign generation that we had last September. September is our month for PBC, where we had patient stories highlighted over the 30 days, and we had a contest for wellness prizes and giveaways to participate in facts. The way we build credibility is that we have a long history. We're 2003 building strong. We are a growing not-for-profit organization with professional presence in the rare liver space. So not just PBC, but in other rare other rare liver diseases. Where we're presenting on patient panels with medical experts and advocating for the unmet needs. So at places like the European Association for the Study of the Liver, the American Association for the Study of the Liver, and these are big conferences and congresses where there's 9,000 people that come. They're clinicians, they're researchers. And to have that patient voice and that patient advocacy group alongside is really important. As I said, our patient volunteers undergo a training in order to support other patients and really building our credibility with key opinion leaders and medical experts we have in Canada and some friends in the US that really are our medical experts that are go-tos because we don't provide medical expertise as part of a patient advisory group. Of course, we have a website with knowledge products that we share. We have been involved in publishing with other alongside the researchers. These are examples of some recent credibility building opportunities that I've been a part of. So I just highlighted some of these. And cultivating influence, we advocate for early diagnosis, treatment, and management so that, people, our members have safe and effective medications. We are involved in research studies and projects where, as we take the results, we translate that to our PBC patients in a way that is digestible for them to understand. People are not interested in the research results. It's more the bottom line, what's coming, what treatment do I have access to? We've been engaged in lobbying regulatory affairs for medications that are in the hopper and aligning our credible medical experts and clinicians and pharmaceutical companies that we have very close ties with and researchers. One of the things that we've been trying to influence as well is CMEs and presenting our patient stories in a curriculum of medical professionals and sharing our lived experience and trials and really highlighting the struggles that we have with poor quality of life. So this is another sort of examples of where we've had poster presentations to be part of. Almost ending off before we go to our Q&A, that I wanted to show you how I've come from being a patient, but a patient PBC and from the left to my donor And then in the transplant world, I've done some work. Great Actions Leave a Mark with living donor organizations, and then a patient advocate, which I am today. Insights, not to do anything about patients without patients, continuing to build relationships with those influencers, medical experts, being in the research arena, go international, talk to anybody and everybody, build alliances, that common purpose, share your knowledge, and to know the power of many. Rare disease advocacy is pretty tough, but really I'm here to say keep going for all of us, right? This is tired work, and we are all diseased, most of us that are doing that. And so just to summarize that if these three elements can work together, that really we have effective patient advocacy groups. So with that, thank you. That's my contact information. And Reggie, over to you.
Thank you, Maria. That was wonderful. We have a question from Tim from Salvame. Aaron?
So the question is how many patients with PBC experience post-exertion or post-exertional malaise. And I went and put that term into our database. The database we use is the All of Us program, of course. There are over 300 participants with PBC in that database, and none had post-exertional malaise. Now, I said, that doesn't sound right. And that's because symptoms like that are rarely recorded in the medical record by the doctor, especially if there are more specific symptoms that would be indicative of the disease that would support billing, because of course that's what the data is collected for. But when I went and I was looking at our database, so since you're sharing, Maria, do you want to go to our website? Or did you, oh, you just stopped sharing? I will.
Oh, I just unshared.
That's
Yeah.
okay. Let me share my screen and I can show you what I'm looking at.
Yeah.
And show you how you can kind of, sometimes you have to tease this stuff apart when you're working with data. So
For sure.
here's our website. Oops, there, where did it go? Come on, get bigger. I was looking up synonyms for post-exertional malaise.
And so
but
post exertion, Aaron, being after exercise.
Exercise,
Is that
exactly. So I went to the
okay?
top comorbidities for PBC, and
Yeah.
actually, this is the test website. I should go to the production site. Hold on a second. Take another second. I looked for terms that might be used instead of PEM, and I saw dyspnea, which is shortness of breath. And I think
Right.
that's where it's how it's being recorded. And that's over 50% of people with PBC are reporting that or have that in their medical
Yeah.
record.
Yeah.
As for fatigue generally, we can look at patient health and see that 7-day reported fatigue is severe and high in over 50% of the population in the All of Us program. So
Yeah. And that is certainly well represented there, right? Like it
yeah,
holds true.
yeah. So that's kind of the answer, Tim. Is that in line with what you're expecting to hear?
Oh, thank you. They just show that terminology are not all kind of interoperable across different diagnoses. That's unfortunate, but that's something that because I imagine it may be a subcategories under dyspnea if we do look more
Yeah.
close.
There is one. There's
Right.
dyspnea after exertion, And that number is about half the level for dyspnea by itself. But again, I think it's just the way doctors are coding it, and it's just
Right.
we have to figure
Yeah.
out, we have to
And
get doctors
as
with
I
more consistent
mentioned,
terms.
yeah. And as I mentioned, often fatigued, what people go to their doctors with and say, I'm tired, I'm fatigued. They might not have the right word to describe the actual feeling of what fatigue is, and that may not be put into the EMR as,
Right.
the electric, yeah, the medical
Definitely not in
record
the
to
US,
pull
where
out the,
they only need it
yeah,
to bill for it. That's why it's the only reason it gets into the EMR.
correct. Yeah,
Any
because
I was
there's
gonna-
no medication necessarily for it, right? So you can't, how do you gonna, to identify it, physicians would then need to treat it. And there's no real treatment for the fatigue part of it.
I also think when you have a patient that has multiple autoimmune conditions, it may be categorized under the other diagnosis. A lot of the time, you just think it's impacted by that. Full disclosure, I am a PBC patient like Maria, and that question never really came up on the fatigue because we talked about it as related to, say, the Hashimoto's or the encephalitis. It's really the other issues that really kind of stands out even more. But do we have any other questions?
I posed another question, which is about the correlation with the liver cancer. And the things like cirrhosis is clearly linked, but I just don't know about whether the incidence will be any different from the 2022 paper, based on if there's any newer data.
Mm-hmm. Yes, we do have, although we don't monitor, we don't collect data on our patients in that way, as an advocacy group. We are aware that some people have been diagnosed with the carcinoma, the HCC.
So I'm doing
And
the
that
query.
is big. Mhm.
Well, I just did the query on the All of Us program, and it looks like there are, technically I shouldn't report that number, but there are 12 patients with a liver cancer and PBC. So this is the PBC count here, and this is the liver count, total 810. It's a crossover comorbidity of 12. So that's the answer to your question,
Yeah.
Tim.
Yeah,
So-
thank you.
So
So that's
yes.
probably somewhat similar to the paper.
Right.
Yeah.
Now, I will tell you from a personal standpoint, my doctor actually did the liver biopsy to confirm or dispel if I had liver cancer as a precaution. And based on that data, it ruled it out. But they did look at that.
The thing is, I was just wondering for people with PBC, whether need to be advised with more earlier tracking for potential liver cancer even before cirrhosis is observable. But that is something that I have in my mind, but I guess there's no very thorough study just yet.
No, I think your point is well taken because my manifestation was I don't have cirrhosis, but they aggressively are treating it. Equirval, which was approved last year in the United States for PBC. And again, trying to identify the markers as quickly as possible so that there's an action plan, and
Mhm.
and that's the biggest thing. And I think that's something that we do
Yeah.
need to look at.
That's great.
So Jordana posted a question about PBC and sphincter of ODDI dysfunction. And again, the numbers, the total number for PBC again was 336. The total in the All of Us program for ODDI is 154. And the overlap though is under 20 patients. So that's a non-reportable number. So, but you know, these are rare diseases. As soon as you take two rare diseases and put them together, you're getting
Yeah.
very, very rare conditions.
Yeah. Yeah. So to address also the ursodiol use, it is a synthetic bile, so it can be used for other diseases. So the sphincter of Oddi, right, all kind of in that area, in the digestive system, is something that the ursodiol can be helpful with. And in fact, I think it's gaining popularity because last year in Canada, we had a significant shortage of ursodiol. So we're seeing that it is being prescribed for other things, and our PBC patients were quite concerned about the availability. So I think manufacturing has picked up, but yeah, interesting.
Okay. We are at time and want to be conscious of everyone's schedule. This will be our last webinar. We are taking the summer off. Our next Autoimmune Registry webinar is going to be in September with Loom for Lupus, with their Executive Director, Estelle Mehta, being the guest speaker. Marie, it was wonderful to have you present today. We learned a lot, and we are very lucky that you shared your knowledge with us. Aaron?
Nothing to add, Reggie. This is great. Maria, thank you very much. Thank you everyone to joining. And if anyone has questions about the All of Us program, please let me know. It's available to any nonprofit in the US. I'm sorry, Maria, you would not, I don't think you can get access to it quite yet, but it will be coming to international participants soon.
Awesome.
Okay.
Thank you very much for
Great day,
having
everybody.
me. And on behalf of the Canadian PBC Society, thank you very much.
Thank you very much.
Thank you
Bye.
very much,
Have a good
everyone.
day.
Bye.